Okay, hello and good evening or good afternoon or even good morning to each and every one of you. My name is Thomas Maniago from Schwind iTech Solutions, and I'm glad to welcome you to the Schwind webinar about presbymax, time for a paradigm shift in presbyopia correction. First of all, I would like to thank Dr. Alan Barsam as he's going to moderate the sessions, and all the speakers as Dr. Michael Luge, Dr. Detlef Breyer, and Dr. Victor de Hatunian. Thank you very much for your participation. Further, my gratitude extends to my colleagues Aliona Kessler, Jens Flügger, and Samuel Abamasquera, and others who contributed to that event. And I give now the word to the moderator, Alan Barson. Please.
Thank you very much for the introduction. So I'm going to talk about a new approach to presbymax and the first clinical outcomes. These are my disclosures. I do also consult for Schwind. So I will do a background to presbymax, as many of the speakers, all of the speakers will be talking somewhat about presbymax, so it'll be helpful to have an overview. This will include some of the principles. I'm going to explain what my practical approach is to the patient workup and treatment, and share with you some initial clinical results of a modification or a new way of delivering presbymax, and I'll highlight it with a case example. Questions will be at the end of all of the talks. So the need for refractive surgery and laser vision correction, and especially presbyopic vision correction options, has, in my opinion, never been greater. The existing problems of contact lens intolerance and quality of vision issues with glasses have been compounded by the necessity for mask wear during the pandemic. The replacement of live in-person interaction, for example, this talk may have been given in a lecture hall where I'd be looking at all of you 100 or 200 feet away. Now you're all on screen, as am I. This is a screenshot of the last Schwind webinar I was involved in. And so everything is now happening at 30, 40, 50 centimeters in the modern post-pandemic world. And so the necessity for spectacle independence and the opportunities to achieve this are greater now than ever before. I'm told now that there have been 26,000 treatments of presbymax worldwide. However, given the incredible power and precision of the Schwind laser at achieving various amounts of asphericity, depth of focus, refractive targets, I would expect the figure to be higher. And I hope that with these kind of educational events and working collaboratively, we can look at ways that we can make the platform more accessible to more mainstream users, because the results are fantastic, which I hope you'll see during the presentation. So prior to doing presbymax, I was using just only monovision, and the problems with monovision are loss of stereopsis, the patient feeling more anisometropic, and in many cases, if you're trying to achieve full spectacle independence or good unaided reading vision for those that are well into the presbyopic age range, then there is a loss of intermediate vision if you use just a pure, simple, straightforward monovision without something like presbymax. The principle of presbymax, well, it's termed a biaspheric multifocal ablation on the cornea. I don't like the term multifocal because I think that it sounds unphysiological. And the reality is, looking at the change in corneal shape achieved with presbymax, what is more being achieved is a hyperprolate cornea, and the prolate cornea is physiological. So to accentuate something that is built into the physiological visual system for our benefit achieves very natural results for the patient. And so I would advise, certainly when speaking to patients, not to use the term multifocal, and also for people that have not used presbymax before, not to confuse the quality of vision achieved with presbymax with anything like multifocal intraocular lenses. So I think it's better to think of it as a hyperprolate corneal shape, or you could think of it as biaspheric, but not really. I don't think multifocal is a useful term here. So there's been an evolution and a little bit of a shift within Schwind as to what the various options are. And you'll be hearing from some of the other speakers about the other options for presbymax. My practice is focused purely on monocular presbymax. And I think that, again, when Schwind talk about the various options, they show you the greater depth of focus and blend between both eyes when a hybrid or micromonovision treatment is delivered, which is where some shape change is induced also in the dominant eye, some change in asphericity, whereas in a monocular treatment, the dominant eye is treated just as an aberration-free, pure refractive treatment, and the shape change and the presbymax treatment is really delivered only to the non-dominant eye. And I think that with smaller amounts of presbymax addition value and taking into account any remaining accommodation in the patient's visual system, including pseudo-accommodation, the reality is that you do get a natural blend and good intermediate vision with a monocular approach. So I think that the slides should be revised. Again, the other speakers will speak more about this, but this just shows you the change in the depth of focus and the change in the asphericity in the various treatment modalities. With a monocular treatment, it's zero, so you're just doing aberration-free treatment only. And then with the hybrid and the micromonovision, you are inducing different degrees of asphericity and shape change in the dominant eye. All of them induce asphericity and shape change in the non-dominant eye. It depends on the amount of addition that you target in terms of the amount of change in negative spherical aberration and asphericity that is induced. The presbymax guide is quite complicated, and I think that this also puts off a lot of users because they feel that they can't integrate or assimilate all of this information in terms of how they could actually treat a patient in practice in their clinic. And I hope that the approach that I'm going to explain today will simplify this greatly. I don't believe that all of these preoperative information is required in order to deliver a safe or effective treatment, especially when you're doing a monocular treatment where you're leaving the dominant eye only given a refractive treatment, so you are not inducing any quality of vision problem whatsoever in the dominant eye. The things that you do need to pay attention to, though, is the optical zones. And this concept of changing the amount of presbymax add depending on the refractive correction that you are also delivering at the time of treatment. So the reality is that a hyperopic treatment will induce negative spherical aberration. The presbymax ablation profile also induces negative spherical aberration. So if you're treating 2 or 3 diopters of hyperopia, you can reduce the presbymax add, and you should do, by 0.1 diopter for each diopter you're treating, because you don't need to do as much induction of negative asphericity in those patients. And the opposite is true of myopia, but to a lesser degree. So you increase the addition by 0.05 diopter of presbymax addition for every diopter of myopia. And then again, this is another decision tree which looks at various pupil sizes, and the reality is that if you're doing a monocular treatment, much of this is either not required or certainly less important. So again, to simplify this for users that have not used presbymax before, if you just do the presbymax monocular treatment, you can greatly simplify things for yourself and your patient and still achieve excellent results. So how does it work in practice? Well, the dominant eye has to be indicated. So in this case, it's the right eye, the distant size of the right eye. The target is always 0, and you put in the subjective refraction. If they're hyperopic, then in my opinion, the cycloplegic refraction is probably better, but you'll have a treatment algorithm already for that, for treating your distance vision patients. And you use the same thing. And then up here, you just indicate monocular. So I'm only doing monocular treatments. And then you have a choice as to what the presby addition can be. And I'll talk about that in a little while. the non-dominant eye always targets minus 0.89. If for any reason you wanted to target less than minus 0.89, you would have to adjust the manifest refraction in order to achieve that. But I've not found that to be required, because you can achieve an adjustment by changing the Presby addition. And the Presby addition induces a shape change in the cornea to make it relatively steep in the center and less steep in the periphery. So that is the biaspheric profile. And it is not exact, but approximately half of the Presby addition is an additional induction of myopia, and the other half is an additional induction in negative asphericity or negative spherical aberration. So this means that if you're doing plus 1.75, you would be starting at minus 0.89 of myopia. That would be the refractive target. But with the plus 1.75, you're giving half of that amount as additional myopia. So the total myopic outcome would be about minus 1.7 in this case. And then you're giving an additional plus 0.85 or more of negative spherical aberration. So you are getting greater depth of focus and greater reading vision on account of the presbymax treatment. And this shows you the kind of profile that you might see, where there's more energy being delivered in the mid-periphery and periphery, and very little and nothing in the center. So you're trying to make the center of the cornea steeper, hyperprolate, biaspheric, induction of additional myopia and negative spherical aberration. Only in the non-dominant eye. There is this reversal concept. I don't mention this to patients, and I don't plan to reverse it in my patients, but in the unlikely event that from treating only the non-dominant eye, the patients complained of any quality of vision issues, you can totally reverse any shape change induced in the cornea with a reversal function that's built into the Schwind. This shows you the reversal for a myopic presbymax treatment that was delivered, and then this would be the reversal treatment for a hyperopic presbymax treatment. So this is the cumulative N number on a variety of different studies looking at a variety of different presbymax treatment profiles. Symmetrical, I believe, is gone now, and it is just micro, monovision, hybrid, and monocular. I'm talking to you about monocular. You'll be hearing from the others about some of the other options. And what you can see is that there is, and you'll know this anyway from any presbyopic treatment that you've delivered, be it refractive lens exchange with multifocal lenses or monovision with laser vision correction or any laser blended vision treatment that you've been familiar with, there's always a trade-off with respect to the quantity of vision you give people, i.e. the amount of spectacle independence that you achieve, and the quality of vision that you can give people, which is, do they feel that the vision is comfortable and natural? And in my opinion, patients do not want to lose quality of vision, and I think it's really important to preserve the quality of vision, and then while you do that, to try and give them as much quantity of vision as possible. So if you can give your patients a perception of perfect quality of vision and as much spectacle independence as possible, then that, in my opinion, equals a very happy patient. And I think the presbymax monocular treatment with the modifications that I'm going to explain to you today that really has achieved that in my experience. And I'll show you my results, which are better than these results that have been published before. So on the previous presbymax monocular treatments, you're having 87% of patients with an uncorrected distance vision of greater than 20/25, and 83% of patients at greater than J2. Okay, for the other treatments, you're sacrificing distance vision a little bit. So you can see less patients are seeing so well for distance, but you're getting more uncorrected reading, but these patients are going to complain of quality of vision. And again, the retreatments. So retreatment and in 14% of patients here, but no reversals required. So what do I do in practice in my clinic? So we do a standard laser eye surgery evaluation, and if you've got specific questions that you'd like to ask about how we do that, then feel free, but I'm not going to go through it all now. We do a test for binocularity, so the optometrist will do this to ensure that the patient's using both eyes together. And then we determine what the reading addition requirement is when the refraction has been corrected. So it's the reading addition. And I only use presbymax if the reading ad needed is more than plus 1.25 diopters or more. If they're less than plus 1.25 diopters, like plus 1 diopter or plus 0.75 ad, if only that is needed, then I still do just a plain monovision treatment because they're in the intermediate range already. I don't believe that there are depth of focus or quality of vision issues with that. But most patients who come to you wanting a presbyopic solution will have more AD. They typically have +1.5, +1.75, +2 or more diopters of AD required. We do a loose lens test, so we correct them perfectly for distance vision. We then put a +1 lens over their non-dominant eye, and we look at the reaction. We don't ask them if they like it or not, or if they prefer it or not, because in general they will not prefer it, and we always counsel patients that there's a 6 to 12 week neuro adaptation period required with a laser blended vision. But if they really hate it and they say, oh, well, I hated that, or that was a problem, then we might choose not to deliver this treatment, but it's very rare. And it's amazing how patients really don't notice very much a +1 flashed up over the non-dominant eye. I believe contact lens trials are very non-helpful because patients are not going to wear contact lenses for 3 months. If they were happy to wear contact lenses for 3 months, then they wouldn't be in your clinic asking you for a presbyopic laser vision correction solution. And the reality is that you have to be patient and allow time for neuroadaptation. And in the very unlikely event that they don't like it, it's very easy to reverse it. You can reverse the presbymax, you can reverse the myopia, or you could reverse both. And only no patients with presbymax have asked me to reverse it so far, but when I was previously doing monovision, I've only ever had 1 patient ask me to reverse it, and 2 or 3 asked me to reduce it, and that's in hundreds and hundreds of treatments. So it's not common that a patient will have a problem with it once they've gone through the adaptation period. And the really nice thing about this, which doesn't apply to multifocal intraocular lenses during refractive lens exchange, is that if they're having a problem with things like night vision, you can fully correct their distance vision with glasses that they just put in the glove box of the car and wear for driving at night. And there's about a 1 in 30 or 1 in 40 chance that they might need that. And patients find it very reassuring that they can resort to that. Not an option for a refractive lens exchange. What modifications have I made to what presbymax advise? Well, presbymax advise starting with a presbymax AD of +1.75. I believe that is too much focused on quantity of vision and not enough focus on quality of vision. So when I started my treatment, I was only using an AD of +0.75 to +1.25. There were no, remember they all end up -0.89, and then you're giving them the AD on top of that. No complaints regarding quality of vision or neuroadaptation, but we had 1 patient where reading vision was not good enough and where a retreatment was required. So I've pushed the presbymax AD number up to +1.50, but I'm not going to go as high as +1.75 because I don't think it's required. The reading vision has been excellent in these patients. Again, we give a bit more for myopes and a bit less for hyperopes as per the Schwind treatment algorithm and protocol. For patients that are more motivated by spectacle independence and we feel would be less bothered by quality of vision, i.e. patients that say, look, I'd never want to wear glasses ever again, not in 5 years, not in 10 years, not in 15 years, we may also give a little bit more. And then a little bit more for those with a neutral or positively aberrated cornea and vice versa. And more for those with a higher reading AD requirement and vice versa. But on the whole, +1.50 has been working very well. And then we try and use the smallest optical zone that can be accommodated by the mesopic pupil. So again, Schwind have got an algorithm that explains what optical zones you can use, and I tend to give the very smallest one that I can because I believe you get a better effect, because the ablation profile will be working between the photopic pupil, the pupil in light conditions, and the mesopic pupil, the pupil in dim conditions. So what are the results? We actually treated 18, this is 18, not 16 patients, 18 patients. And this is a cumulative unaided distance visual acuity. So if you think back to the slide I showed you before, where there was, I think, 80% better than 20/25, we're having 100%, 20/20 or better, 0 log MAR, and 90% is better than 0 log MAR. So it would be 20/16 or negative log MAR -0.1. So fantastic distance visual acuity. Preservation of quality of vision, no problem. And then what about reading vision? Well, again, we're seeing fantastic reading vision. So logMAR 0 is equivalent to J2, and we have 90% of patients at J2 or better. And then all patients are at J3, J4, which is what I call social reading. So a very high degree of total spectacle independence with total preservation of quality of vision. And this should be within the remit of any refractive surgeon to use, to apply, and for the patients to enjoy the results. And this just shows you the spherical equivalent accuracy in the dominant eye is very, very high with the Schwind. This is the 1050 RS. So, and that's important in these monocular treatments or any presbyopic presbymax treatment. So we're able to achieve a very tight spread. So here's a case example. I'm deliberately choosing a difficult one because, you know, if it was a high hyperope, they're very easy patients to make happy with presbyopic treatments, but low myope more difficult. And to make it even more difficult, he had been treated before with myopic LASIK 18 years ago, and he was a consultant physician. So, and a low myope at that. So the dominant eye is the right eye, the non-dominant eye is the left eye. Unaided vision is very poor for distance. It's reasonable though for reading. And what you can now do, measuring the corneal flap, is actually quite straightforward now with OCT. 165 micron flap gives plenty of room to create a new flap above. And this is his topography in the non-dominant eye, because this is the one that I want you to focus more on, because the dominant eye is just having a straightforward aberration-free distance treatment. And the non-dominant eye, a relatively regular cornea. Pupil size, scotopic conditions, 5.3 for the right and 5 for the left. That's totally fine. Schwind will not want you to treat if the scotopic pupil size is too large. And also you can see here on a pentacam or any equivalent thing, you see what the pupil is in light conditions. It says 2.3. And again, if this is too big, then also you won't get the treatment required, because you need some depth of focus from a small pupil, and the profile is working within the range of the dynamic pupil. So between 2.3 in this case for the left eye and 5 here in the left eye is where you're getting the effect. And the effective optical zone is always a bit smaller than the optical zone you key in. So you can key in 6. When you look on the topography, you'll see that the optical zone is often smaller. We're doing, again, it's biaspheric, but it's a monocular treatment. The distance eye is the right eye, so this is the treatment happening to the left eye. The addition is plus 1.5. I told you that was the figure that I often use. This is the treatment. So he's being left minus 0.89 with an addition of plus 1.50. Post-operatively, this is at 6 weeks post-op. Here's 6/18 unaided, which is 20/60, but actually many patients are 20/40 or 6/12 or 0.5 decimal. So the preservation of distance vision is greater on account of this treatment than it would be if you were doing pure monovision treatment. And then N5 unaided, which is J2. And then he refracts here to about 1.5 spherical equivalent. So you're not, but you're still achieving this fantastic reading vision. Patient 62, and it was a low myope. Here you see what I talk about at the optical zone. You can see here the cornea is relatively steeper in the central area and relatively flat in the peripheral area. And this is what creates the biasphericity, the negative spherical aberration, minus 0.61 on this. If you're looking at it on the paramus, you have to change. This is a full pupil. You have to change to probably a smaller pupil to see a more meaningful and negative spherical aberration figure. So in conclusion, I've given you a little bit of a background to presbymax, shown you some of the principles, given you a practical approach to patient workup and treatment that I think is really within the remit of any laser refractive surgeon. Looked at some initial clinical results, highlighted it with the case example, and we will leave questions for the end. This is my email address. If you want to email me personally about anything, I'm happy for that. I'm now going to get out of this and see if I can introduce the next speaker. Now the next speaker is Michel Luger from the Netherlands, and he's going to be talking about hybrid blended vision with presbymax. Michel, over to you.
Hi. Hello, everyone. It's a pleasure to share my experience with presbymax. So it's a pleasure to share my experience. I think I've been using presbymax for over 10 years right now, and we initially started out with binocular symmetrical approach, which had variable results. As mentioned earlier, so in some cases the quality of vision degrades when doing symmetrical presbymax. So actually we stopped using that, and then together with Sam, I pushed Sam a little bit to develop the hybrid version. I had some experience with camera, and in those cases people have one eye for distance and one eye for near, obviously, and that prompted me to maybe use this with presbymax as well. So when we restarted, we did it on one condition, that we should follow up very precisely on this type of procedures to make sure that we did the right thing and created only happy patients. Let me see how I can get to the next slide. Yeah, okay, so no financial interest. So we introduced a presbymax hybrid. We did a series in 2012 that we studied closely. So all the details that I'm showing you today will be 8 years old, actually, by now. And to summarize what hybrid means, it's actually a micro monovision technique, as mentioned just before, with the addition of enhanced depth of focus by inducing negative spherical aberrations. Excuse me. In different ways in both eyes. So the distant eye we target for emetropia, and the near eye we target for minus 0.9, and a different amount of addition is induced in each eye. Anyway, so we apply different depth of focus in the distant eye and in the near eye. So half the addition in the dominant eye and the full addition in the near eye. Okay, well, we've covered this. Okay, so when we started with the study, we wanted to use validated questionnaires for near vision quality and general quality of vision. So we used this near activity visual quality questionnaire on the left, and also the Macalinden quality of vision with the validated pictures. Further, we studied contrast and disability glare, corneal aberrations, and ocular aberrations, and all procedures were performed with interlace at that time, and the MRS 750S. We studied we published the 1-year results in American Journal of Ophthalmology in 2015, and a 6-year follow-up last year in Journal of Refractive Surgery. So we recalled all the patients, the whole group that we did in 2012. We recalled them 3 years ago, and unfortunately, only 19 patients wanted to participate. The rest did not have interest to join or to cooperate. But still, so we reran all those 19 patients, and we measured them at 6 months, 6 year follow-up, and we reran all the data from the initial treatment. So these are the numbers. Hope I can see them all. So the average age was 51. So all presbyopic patients, obviously, with a spherical equivalent varying from minus 4.5 to plus 1.5. So from myopia to hyperopia, very little astigmatism, and good visual acuity, corrected visual acuity at all distances, but all were highly presbyopic. When we look at uncorrected distance visual acuity, we saw there was a trend for improvement in the near eye, but otherwise it remained really stable. These are binocular results. And with regards to quality of vision, very important, of course, there was an initial deterioration. So in the first year, patients complained of some degradation in quality of vision, and that recovered completely over time. So the main issues at 12 months that the patient had were halos, blurred vision, and double vision. And obviously those are mainly because of lack of adaptation, because there's a difference in both eyes, and the non-dominant eye has more visual symptoms. At 6 years, however, it was improved opposed to 1 year post-op, but even improved opposed to preoperatively. So the quality of vision was really excellent at 6 years post-operatively. Looking at refractive outcome, at 1 year we saw a good separation between distant eye and near eye as intended. So the distant eyes were on average emetropic, and the near eyes were on average between -1 and -1.5. So excellent monovision applied as intended. Yeah. And the spherical equivalent is there is some progression towards hyperopia in the long run. So some presbyopic progression over time in the 6-year follow-up. Refractive astigmatism was very stable. It was low to begin with, but really stable over time. Summarizing distant visual acuity and refractive outcome, all patients had binocular 20/20 uncorrected vision, and the quality of vision was comparable, even a little bit better than preoperatively, where halos, blur, and double vision resolved from 1 year on. We had a good separation between distant and near eyes, and the stability was achieved at 6 weeks follow-up, and there is some progression of presbyopia and some hyperopization over time. Uncorrected near vision at 1 year, there's 90% of patients had J2 or better, so that's really excellent. And over time, we saw some presbyopic progression also here, where the near eye remains stable, but the distant eye has some progression over time. And if we look at the near activity visual quality, there is also some sign of progression of presbyopia that we also saw in the questionnaires, where patients showed. I mean, there's overall still a big improvement of all elements in 6 years after the procedure, but opposed to 1 year post-op, there is some degradation of the really up close near vision. So 40 centimeters was a little bit worse than at 1 year, and intermediate vision stayed quite well. So on average, uncorrected near vision was J2 binocular, and the near activity visual quality improved from very little to very high satisfaction. And there was, although it became a little bit worse from 1 year up, they improved on all items and were very highly satisfied. Distance corrected near vision at 1 year, there was an improvement in the first year, and it continued to improve. And there was also here some presbyopic progression over time. Looking at the defocus curve, this is actually the area of multifocality that we were looking for. There is quite some improvement in the defocus curve, but it declines slightly after the first year. So if we look at the defocus curve, there's no loss at best focus, so that's a very important and good thing. And no change for intermediate, and a mean gain of 1 line for near vertices. And but there's some deterioration from 1 year follow-up, some loss of multifocality. Aberrations showed clearly that spherical aberration, negative spherical aberration, is induced, and that remains very stable over time. And we saw that the corneal spherical aberration and the ocular spherical aberration were decreased by almost minus 0.3. Contrast sensitivity improved to my surprise. So in 1 year follow-up, it improved over time, and that goes for normal contrast sensitivity as well as contrast sensitivity measured with glare. So in summary, contrast sensitivity was better. It was similar to pre-op at 3 and 6 months, and better than pre-op at 1 year. And the same goes for contrast sensitivity with disability glare, indicating high quality of vision again. So in conclusion, we can say that stable enhanced depth of focus and marker vision are achieved as intended, and there are very high satisfaction levels of visual quality and visual performance over the long term. 100% of patients had 20/20 for distance and an average uncorrected near vision binocular of J2 or better. So presbymax hybrid is a really good solution in presbyopic patients that are too young for IOL exchange. I would like to demonstrate that in a few cases. Case one is a very typical hybrid presbymax patient, 51 years at the time of treatment, and he wanted to correct distant and near vision at the same time. He was 2016 corrected and uncorrected, so it was still with hyperopia some good amount of focusing, accommodation, and low astigmatism. And after the procedure, the uncorrected distant vision was still perfect, and he achieved J1 uncorrected near vision. So a very satisfied patient, and you can see in the topography very nicely how the central myopia is achieved. We had a little bit under 20% retreatments in those initial series, and this is a typical retreatment case. The patient was originally myopic, 49 years at the time of first treatment, and treated for both distant and near vision, of course. And we ended up with a little bit too much myopia in the dominant eye, so distant vision suffered, and she wanted that to be corrected. So after retreatment at 12 months post-op, actually we just did a flap lift, aberration-free retreatment. She achieved 2016 uncorrected vision and J1 for near, so she ended up to be really satisfied. So with a simple aberration-free retreatment, you can resolve those cases. So we did around 20% retreatments. Most were for distant vision, because that's the thing that patients usually take for granted. They want their near vision corrected, but they forget that distant vision is really important. And once they find out that their distant vision is not as good, they want that retreated, and that's easily to be performed with aberration-free retreatments. We did some near eyes, and we did 3 reversals because patients were not happy with their distant vision also. In general, the retreatments, they performed really well. As we can see at the after retreatments, the distant vision and near vision both improved, as is also visible in this graph. So aberration-free retreatment works really well. Then the third case, I think it's very nice in this kind of procedures to have a sort of safety net, and the presbymax reversal is the safety net that you need when patients are not happy. This was actually a case from the first series where we did a symmetrical correction, and this lady, she was 49 years at the time of treatment. We corrected her myopia and in both eyes, and also treated her near vision with presbymax. And so this was pre-op. She was 21,000 distant vision acuity uncorrected in 2016, so very excellent distant vision. Near vision with correction was quite good, and distant corrected near vision was not as good. She was around -4 and in both eyes, and so we went ahead with the symmetrical presbymax treatment. So her distant vision was not as good, because her distant vision post-op was not as good, and she was unhappy about that, so we had to retreat that. This was the original presbymax treatment, which induces central myopia and corrects the distant vision, and this is how she ended up after this first procedure. The dominant eye had 20/40 uncorrected vision and 20/25 best corrected vision, whereas she was 2016 pre-op best corrected vision. So she suffered some degradation in visual quality and lost quite a few lines, and wasn't happy about that. And actually we induced too much negative spherical aberration. So after quite some time, a few years later, we did a reversal, and this was actually done with PRK, so on the flap. When Sam designed this reversal software beforehand, it was not yet available, so we had to wait for this. And it worked really well, because after this reversal, She now is 2016 in the dominant eye without any refraction. And so she was the first. By this way, she became the first hybrid patient. And it's nice to see that the wavefront after its reversal is exactly the same as preoperatively. So it's a true reversal of the spherical aberration induced by the previous treatments, as you can also see in these topographs, where the spherical aberration is exactly the same as pre-op. Okay, so where are we at 6 years? This is a very complicated graph. You can look at these graphs in the publication, but I'll summarize it for you. The distant visual acuity after 6 years is stable. So with 100 patients, 100% of patients having 20/20 or better uncorrected distant visual acuity, there's very little loss of lines with corrected distant visual acuity opposed to pre-op. And the near eyes, they lose a little bit of 16% loses 2 lines of corrected distant visual acuity, because in those eyes more spherical aberration is induced. The near vision, there's some drift over time because presbyopia progresses, and there's still some part of the near vision comes from accommodation, and obviously accommodation is lost, and there's also some change in the refraction over time. But as a whole, the refractive correction is excellent in linearity and in precision, but we do see some drift in distant vision and in near vision. So can we improve this over in the long term? Well, there are various approaches available. The first one, to be aggressive, to make it lasting, I think that's a little bit too much to perform, where we aim the distant eye at a little bit minus and the non-dominant eye at more myopia, and with a stronger addition. I mean, this will last a long time, but it will induce quite some differences between the left and the right eye, so the dominant and non-dominant eye, and the difference should not be that big to make patients happy. So I think that's a bit too much aggressive to do it that way. The second approach is what we use most of the time, which is actually the hybrid, in which the distant eye is aimed for emmetropia and the non-dominant eye for almost -1 diopter of myopia, with an addition in the non-dominant eye of 225 and a little bit less, half of that actually, in the dominant eye. And that will last for 5 years at least. And in those cases where we see some drift, you can easily enhance that with a aberration-free retreatment. And I think that's important, because in the long run, after a couple of years, you do not want to lift the flap and retreat, and aberration-free retreatments can be easily performed with PRK. If you do a milder version, it's always a blend, of course, between inducing symptoms and achieving good vision. But in a milder version, the quality of vision initially will be quite good, but the long-lasting effect of the treatment will be shorter. So after a couple of years, you will have to retreat them, and maybe even increase the asphericity, so do another presby treatment. And therefore, for those treatments, you do need a flap. So I think that's not the way to go. So, and all patients need neural adaptation, of course. So final comments, this is my last slide actually. We now use a different approach where we do more customization. We look on the pre-op spherical aberration and look at the amount of spherical aberration induced by the treatment, and we base the addition and the amount of hybrid that we apply on those numbers. We also see, at least in the Netherlands, that the demand for LASIK in general is low, because it has a bit of a bad connotation. So people tend to prefer IOLs, they tend to prefer SMILE, and they do not like LASIK so much. And LASIK at this moment is the only way to perform presbymax. Another very important thing is that you should prepare your patients that the effect of the presby treatment, it will wear off over time to some extent. I mean, they will, even in the long run, have some benefit of it, but the effect will not be as good as initially, and they should be prepared for that. So they should either have a retreatment or accept the fact that they will need some reading glasses. For SMILE, there is always the possibility, of course, to use monovision, although it would be very nice if some presbymax negative spherical aberration could be induced with that procedure as well. For the rest, I think presbymax will last at least for hemetropes and the hyperopes. So thank you very much.
Thank you very much for that talk. The next speaker is Detlev Breyer from Germany, who's going to talk about when do I prefer presbymax laser vision correction as a first-line therapy in the correction of presbyopia.
So thank you very much. Very kind of you asking me to give this presentation. And the challenge has been there before, as I was invited in Paris for a talk. Is it time for a paradigm shift in presbyopia correction? So I already did have some slides. Thanks for that. I asked myself then how to approach this topic. What are the problems in correction of presbyopia? And elective surgery, always ethics is one of the biggest problems. And up to now, we don't have really good accommodative optics. So the compromise is, of course, visual acuity. So up to now, as much as I know, multifocal IOL implantation, clear lens exchange is the most common surgery for the correction of presbyopia by far. So let's have a look at the ethics, because I think this is very important. And if you talk about ethics, you have to talk, of course, about complications. But a complication frequency, in severity, which means up to the loss of vision, and in reversibility, and alternative surgical procedures. So thank you very much to my ACOS friend, Arthur Cumming, who did this presentation at the ACOS meeting 2019 in Sitges. So I stole his slides, and he also mentioned the different risk and the gravity of risk, and it was an excellent presentation. If we ask ourselves if there would be the auditorium sitting in front of me, we would see that much more presbyopic laser surgeons had laser surgery than multifocal IOL implantations, according to the literature. So, and it was very funny, my Cologne friend Omid Karmani was asking on Facebook half a year at the beginning of the year, so what should I do, which kind of correction? And as you can see at those times, I didn't have the presbymax, so I said clear lenses. So presbyope, go for laser vision correction and do a multifocal IOL implantation. Not to forget what many patients don't know, we just try to educate them, then LASIK is safer than contact lens wear due to microbial keratitis, upcoming now with an even better argument of COVID. What do we do when we treat presbyopes with multifocal IOLs? We steal them light transmission. We don't do that with laser vision correction, but we do that with light transmission. Then with MRI surgery, you see the risk of potential catastrophic complications or some. So, and if we do this kind of surgery to young, more or less young hyperopes, you have, due to the liquefied vitreous after surgery and the moving of the vitreous, a higher risk of retinal detachment. So that's also something that speaks against MRI implantation and for laser vision correction. At the end, with clear lens exchange, you can have really visual significant complications, but not only acutely, but also on the long-term consideration as shown here. Then one argument of the defenders of clear lens exchange is that it's permanent. I doubt that, because if you look at those graphs, how astigmatism changes over life, and you have a trifocal diffractive IOL implanted, you will surely have to do laser vision correction later on in life, because the astigmatism changing over life will also ask for laser vision correction. But on the other hand, what is really permanent in diffractive MRL is halo and glare. So are you still thinking that MRL implantation is the best way to correct presbyopia? It's the most common way, but I don't think it's the best way. So why is it? We talked about the ethics, which I think is a huge issue in presbyopia correction. But if we talk about accommodative IOL and optics, that would be the best we could have. I was invited at the ACUS meeting 2020 webinar and talking about the 3 front runners of accommodative IOL. And despite the Lumina from Ecolens International Netherlands, it's still more rumors and science. Jorge Alio did very great science on the Lumina. So who is interested in that, just search JCRS and Jorge Alio, JRS and Jorge Alio. So what if you don't have accommodative optics right now is our optical armor to fight presbyopia. At the end, we do have 5 optical principles left. Monovision, not very well tolerated. If somebody wants to read in far, even not possible, I'd say. Blended vision, which is much smarter. We have refractive optics, diffractive optics, and the pinhole effect. This is a slide from Dan Reinstein showing that what we have heard before, also with Michael and Alan, that there is no loss of contrast sensitivity in blended vision, and that you have a quite pretty high tolerance rate in blended vision. So one argument of those defending cataract surgery very early is that anyway the patient will have cataract surgery later on. Looking at the data, only 1/3 of those patients we could do laser vision correct, would later get cataract surgery, but 10 and 15% will have AMD. And we know that implanting IOLs is not really protective for AMD. Also important, what happens with a retreatment? Is the patient adjustable? Yes, in laser vision correction is. In clear lens exchange, once you have done the outliers, 20, 25 or worse, you can't really individualize the vision anymore. So those are the patients who cost you a lot of chair time in comparison to laser blended vision. So the IOL sibling, I started with Prescient 8 years ago, and I kind of stole the idea from Dan Reinstein and did the blended vision with low edge segmental refractive IOL. And I'm doing this now for 7 years, and I'm very, very happy with this principle. So, and it seems like I wasn't the only one who was happy with that principle. So I think looking at ethics and looking at optical principle, there should be definitely a change in the correction of presbyopia. So first of all, blended vision is number 1. Then if you have higher order aberrations, you could even use SMILE or ICLs. Refractive low edge blended vision is number 3. Number 4, trifocal IOLs, they're fine. Nevertheless, permanent halo and glare, and retreatment possibilities are restricted, as I've shown. So we really have to take the individual approach for our patients in consideration. And there again, blended vision is the best we can do. So one size fits all? No, I don't think so. I think we have to do customized surgery. So there should be a change. So my problem was gaining 25 Ks in 25 years of marriage was humiliating enough, plus the less intellectual properties and memory, always looking for my readers was really annoying. So wearing readers on top was simply too much for me, for my vanity. So I felt out dependent and challenged by reading glasses. So my insight was 8 years working with Presbyond and the Düsseldorf formula. And for me, blended vision always was a success story. Hundreds of happy and thankful patients. So since 3 months, I bought the presbymax because I really think it's a great excimer laser with a superb eye tracking system. And I had an experience with changing the alternate target refraction of 0.8. It is used by presbymax to 1 1.5. And I had the same great experience I had with the Düsseldorf Formia or Prescient. So originally I wanted to go to Den Rheinstein, but then there was a COVID shutdown in April, so I couldn't go to see him. On the other hand, the COVID shutdown was a real time gift, so I timed for laser vision correction. I don't have a femtoLASIK surgeon in-house, so a trans-PRK, SmartSurf, presbymax, all that was a solution for me because I had enough time. Nevertheless, I had surgery on Friday. On Monday, I went back on doing 20 cataracts and seeing 40 patients. So I think that's a proof of concept if you have 8 years of experience with the surgical method and then you do it to yourself. Here you can see the subjective refraction pre-op. I think I have kind of eagle vision. I didn't have a detached vitreous, so clear lens exchange clearly for me was a no-go. I would never have done this. This was a treatment planning. I call it Presby ADOF because I used the presbymax profile, but I changed the target refraction to -1.0. I wanted to be able to read even small print because I use my mobile very often during the day. And if you use your mobile, sometimes you have to read small print. That's why small print reading for me was very important. And I used a Presby edition of 1.25 diopters. Those are my personal results, and I think that really is a proof of concept presbymax works. This is a Pentacam pre-op and 1 month post-op. This is epithelial pachymetry pre-op and post-op, and as you can see, the epithelial remodeling is still going on, so that I don't expect my status right now to be at the final stage already. I will tell you more about it in 1 or 3 months, whenever there's time to. But also in the series, you can see 4 weeks post-op and 6 week post-op. There's really still a significant change going on. So I myself, after 6 week post-op, I'm really happy. I can read near without any addition, quick reading 20/20, slow reading even better, and here you can see me really smiling on this picture because when I take a reading light, it's even 1.5. So you really can't expect more from a surgical procedure. So when you ask me, when do I prefer presbymax laser vision correction, I would say always. I only think of clear lens exchange if it should be if laser vision correction is not possible for medical reason. Otherwise, I absolutely do prefer laser vision correction. Thank you very much for your kind attention. I hope I stayed in time. Thank you very much.
Thank you very much. The next patient, the next talk is Victor Dehautunian from Austria, who's going to talk about evolving presbyopia marketing in Europe.
So let's start with the first slide. So treatment, population and potential. So far for laser vision correction, the most popular treatments are for myopia, hyperopia, astigmatism, and irregular corneas. Presbyopic treatments, I think they are incoming, they are on the market, but they are not that popular yet. So when we look at the population in Europe in 2020, we have around 750 million people. It's a huge number. When we look at the age pyramid, so we look at we start with above 3% of population starting age of 30, and it continues up to 55, 59. And it's right in the middle starts the presbyopia, so 40 to 44 up to 50, 59, and then we have 60, 64, it starts to decrease. So this is the potential of presbyopic treatments. When you look here at the segmentation of the patients, so we have a millennials, Generation X, baby boomers, and then older people. So when you look at the millennials, especially now at the COVID situation, the millennials, they suffered the biggest decrease in income, they got unemployed, and however, the Generation X and the baby boomers, they got spared from that. So how do we treat presbyopia? We can treat presbyopia with laser in form of monovision. It's the old way, and now the newer way, it's presbyLASIK. We have 3 companies on the market. From Schwind company, the presbymax, from Zeiss company, the company presbyont, Supracor from Bausch & Lomb, and I think there is one more profile coming from different company. And on the top of the laser, we can treat presbyopia with implants. So what are currently the most popular presbyopic treatment? Of course, they are IOLs. So we can perform either implant monofocal lenses with monovision, we can implant multifocal lenses, there are tons of them on the market, and most recently the introduction, I mean, they're becoming more and more popular, the extended depth of focus lenses. So why laser vision correction is not as popular as lenses currently? So the doctors, so we need more specific technology, which is expensive. We need a performant excimer laser, which can perform also these presby laser profiles. We most likely need a femtosecond laser, as I think most of the treatments are performed with a femtoLASIK. We need to pay additional licenses. We have additional costs because we need to pay additional licenses. We have a more sophisticated workup with the patient, and the patient selection, I think it's even a little bit more difficult than with a lens implantation. And we have a problem with presbyopic progression. So we need this treatment strategy over time. We cannot tell the patient that it's one-time treatment and you will be sorted till the end of your life. And of course, we need this specific knowledge of presbyopic profiles. And also, after performing presbyopic profiles, we need to tell the patients that the chance of getting a retreatment is higher than in a standard myopic, especially myopic procedure. So more chair time, more cost for us. On the other hand, when we talk about marketing, we have several problems. So I divided it into groups. Patient problem. So patients said they never heard it's possible. It's not popular at all. They hear negative voices from doctors, and of course, they fear of any treatment on their eyes. When you look on the other side, so they are doctors, they are not involved at all in refractive surgery, so we're getting negative marketing from their side. So patient says that they hear from doctors that laser works only up to age of 40 to 45, presbyopic treatment are not possible, laser no way, or even I hear for example, in Austria, that even standard myopic or hyperopic treatments are not precise. So my approach to presbyopic correction, what did I do? So I developed a personal interest in presbyopia. I visited courses, read some papers, and I exchanged with other colleagues, which I think this was the most important part. And I increased the offer for all presbyopia treatments. So I started to offer several types of trifocals with different additions. I offered different types of extended depth of focus lenses. Now soon I will offer actually I started to offer also monovision with ICL. Soon we're gonna have the CE approval is already on the market from Star Surgical for the presbyopic ICL. So I have an evolution from laser vision correction. In the past, I was only offering simple monovision with laser and one trifocal IOL. That was my presbyopic portfolio, and this became a complete broader portfolio of lens products, ICL products, and of course presbymax. So very important is patient selection. We need to promise the patient what you can achieve. Very careful patient selection is crucial. So I target patient wishes and patient habits. I monitor the outcomes, not only the refractive outcomes, but also the patient satisfaction outcomes. As satisfied patient leads to increased word of mouth marketing, which is the most precious marketing we can ever get. And very often patients are looking for lens solution. They come because the neighbor got a trifocal IOL. And we can also convert this patient to laser to laser procedure, as Detlef said that his first choice now is a laser solution, as it's safer, as we don't have as many possible complications as with IOL surgery. We need to listen to our patients. So laser is definitely the least invasive treatment. Long term, there are patients. I have two types of patients. One patient says they want the least invasive treatment, and the other group, they want only one treatment forever. So we need to listen for them and choose the right procedure. So what was my challenge? I started to update my website. I increased the presbyopia content on the website. It's still in transition, still in progression. I changed the search engine optimization. I changed the AdWords. It gives a better and more precise targeting. I changed also the content on Facebook and Instagram posting. However, the marketing works differently in different countries. So I'm working in Austria, Switzerland, and Poland, and some marketing strategies which work in Austria, they don't work in Switzerland, or they don't work in Poland. And the opposite, whichever works very good in Poland, has no chance in Switzerland. Mentality of the nation is a key factor, and local competition also might influence the marketing. So we need to look at these 2 points. My marketing advice, you need to try to find the best marketing spot solution in your region. Monitoring is the key success, as you can take as you can get the key issues, key messages, what to perform. And I think also invest part of the marketing in innovative ideas. I call it, it's like a casino. Some of these ideas you might lose the money, and on the other hand, it might be the spot and you might gain 20 times. Very important to talk to patients, to ask them how do they find the clinic, and then of course you can adjust accordingly. And never put down competition who is not performed presby LASIK, just IOLs. This is a personal solution of the center or of the doctor. It's not good, it's not bad. I think it's very important to stay neutral. And the quality of the treatment and patient experience is the most important to grow the practice. When we talk about the financial aspect, in the past, I didn't charge for monovision. And when I started to perform presbymax, I started to charge a fixed fee per patient, indifferent of presbymax type, monocular or hybrid, for one or for both eyes. In the meantime, the fee was increased, and I'm charging now exactly the same fee for monovision or for presbymax. However, I perform presbymax in 95% of cases. The side effect of promoting laser vision correction for presbyopia is the growth of refractive lens exchange with premium IOLs. So this leads also to increase of practice gain. So what and how should we change the strategies? So besides online and offline marketing, we should teach local colleagues maybe to stop or decrease the negative marketing that treating presbyopia with laser is not possible. Producing excellent results leads to best marketing in terms of word of mouth. Involving other doctors in the treatment is also helpful, so we can send, even if the patient comes not as a referral, but we know and they have other ophthalmologists, we can send them reports, and of course the examining non-refractive ophthalmologist, they see the results, so maybe this can convince them. We should produce a lot of patient testimonials, written and videos. And patient meetings also are required. So sometimes it's also helpful to let the preoperative patient with the postoperative patients to meet together and to exchange their experiences. And this also increases the trust in the clinic. So as for the discussion, I leave it open, maybe some other ideas how we could increase the numbers of these least invasive procedure, laser vision correction for presbyopia. Maybe we can involve manufacturers, and also how to put together or parallel treating presbyopia with intraocular lenses and with presby LASIK, that we don't compare it too much and that we cannot tell one is better and one is worse, because comparing those two strategies, I think it's not a very good idea. Thank you very much.
Okay, thank you. So let's switch over to the discussion section.
First of all, thank you very much for the presentations. Really appreciate it. There are some questions from the audience, and the first one was, what is the experience with trans-PRK and presbyopia correction? And maybe as one of you has treated himself with trans-PRK and presbyopia, so maybe we can address this question right away to Dr. Breyer.
So I personally did trans-PRK because, as you have seen, I didn't have another possibility. But would I recommend it to my patients as a first-line therapy? Personally not, because I think there's a longer time of suffering. There is a slow recreation time, which still goes on after 6 weeks. For me, it's not a problem. I know it will be good. I have 8 years experience, so I'm relaxed, I'm cool, I don't care. But I think for patients, this might be a hassle. So first-line therapy for me for sure is femtoLASIK, presbymax, and second is trans-PRK. For example, if you have a boxing sportler, whatever, then you shouldn't do a femtoLASIK, or I would do. So it's good to have a trans-PRK, but it will never be my first-line therapy.
I think also I can tell from my experience from monovision, if we need to retreat the patient, then it becomes a little bit problematic, because if the patient, as Alan said, retreating patient increases the satisfaction. So performing a surface treatment, first we need to wait a minimum 6 months to treat the patient, and then the patient needs to go again through the 3 or 4 months till the vision becomes better. So the process becomes very long. I mean, I'm not talking about the epithelial remodeling, but just about the length of the process.
Thank you very much. One other question was, how has using presbymax impacted on your clear lens exchange practice?
I personally implant clearly less. As I said, 2 years ago, I was already on my way back. But since I gave the presentation at the ISOP meeting, and I was really deep thinking about the ethical problems and the optical aspects, I think it's kind of a sin to do clear lens exchange if you don't have medical reasons. I think corneal surgery should become number one.
Yeah, I agree with that. I think that many surgeons unfortunately don't understand the benefits of laser blended vision, or what can be achieved with laser blended vision. And I think that all refractive surgeons should first of all evaluate a patient for the suitability, if they're presbyopic, first of all evaluate the patient for suitability of laser blended vision, and then only choose refractive lens exchange if there's a good reason not to do laser blended vision. And many surgeons have criteria that are too prohibitive. The reality is that laser blended vision gives almost instantaneous results with total reversibility in the rare instance that you would need it, and much more physiological vision. And that's not the case with even the best trifocal lens. So yeah, I totally agree.
Yes, same here. I think it has not affected my practice of refractive lens exchange, because I think you should only do that when there's either cataract or visual detachment. In other cases, if laser is possible, that's the best option also for presbyopia correction.
Okay, very good.
I ask you a question here. There was a question from the auditorium about the device like the Paramis, who is able to measure the accommodation. There's an evaluation functionality to measure the accommodation of a potential patient. And is anyone of you using the Paramis with this functionality, or a similar device who is capable to measure the accommodation, the remaining one?
No. Not me.
No. Me neither.
I do, just for the documentation, but it's not a main part in my decision tree.
Okay, so you evaluate this accommodation in any other form with the lenses, with the trial lenses? I think Dr. Alan Barsom, you mentioned about some tests about this at the beginning.
Yeah, you can extrapolate the amplitude of accommodation if you know what the reading addition requirement is. So you don't need to overcomplicate the accommodative function of the patient. What we do is we look at their uncorrected near vision, binocularly and in each eye. We look at the distance refractive corrected near vision in each eye, and then we look at the additional reading addition that's required in each eye, and then you have an idea of how much the patient stands to gain through or needs through laser blended vision.
All right. Yeah.
And I mean, we anyway treat every patient as there would be no accommodation. At least I do, because I want it to last long. How is it with you, Michiel Luger?
Yeah, well, I'd like to. Well, it's a mix. I mean, you want to induce as little side effects as possible. So also you want to induce as little sort of aberration as possible, but as much as required to get good reading vision. So I think initially you will. I do depend a little bit on accommodation to some extent, and that will wear off over time. So I think that's the biggest reason why we see that over time the reading effect diminishes slightly. But I think that's better than to overdo it initially, to either get too much monovision, so myopia in the near eye, or to induce too much spherical aberration, because that will deteriorate the quality of vision. But you should prepare the patient and tell them in advance that they may need a touch-up in the long run.
Okay, thank you. Jens, another question in the pipeline?
Yes, there's one more question saying, okay, if you treat it with presbymax and you need a cataract, which IOL would you choose? And how to calculate the correct power?
Well, I think power calculation is not that much of an issue anymore, although predictability is less than in a virgin eye, obviously. But I think the nice aspect of having had presbymax prior to cataract surgery is that the negative spherical aberration induced remains and is helpful in also after cataract surgery. So you need less multiplicality in the lens actually. So you can aim for a less multifocal IOL, such as the 1.5 diopter edition lenses IOL that I used to use quite often in those cases. Or even a monofocal IOL with some monovision will help as well.
I think that's a point, because now we do have perfect aberrometries. We can do laser vision correction according to aberrometries. So why not continuing to the model the patient is used to? So I think we, as Michiel rightly said, just continue with the monovision when you do cataract surgery. Use the effect of the cornea. And according to aberrometry, you choose the right IOL.
Yeah, that's what I do. And I normally like to use a zero aberration lens in these patients. So I don't use Alcon or J&J lenses because they're both negatively spherically aberrated. And I use a zero aberrating lens. Rayner makes zero aberration monofocal lenses, which work really well. And actually, they've just brought out a positively spherically aberrated lens in the unlikely event that you ever wanted to reverse the negative spherical aberration in these patients.
Okay.
Thank you very much.
So there is a question, what about emmetropic patients? Any precautions if they are coming for our presbyopic treatments? Are they good candidates, critical candidates? What can you say to these emmetropic patients?
So in my presentation, I had a total selection of patients through all prescriptions, including emmetropes. So of those 18 patients we treated, at least 3 or 4 were total emmetropes. And I think that laser blended vision is great in emmetropes because you don't, especially if you're using the monocular presbymax, because you're not giving up anything. And in some patients, if they have less than half a diopter of spherical equivalent hyperopia in the dominant eye, you only need to treat the non-dominant eye, which is acceptable to these patients. So it works very well. I think that I don't have any reservation at all in doing laser blended vision on emmetropes. I'm very, very cautious indeed, though, however, in doing refractive lens exchange in emmetropes. So I rarely do refractive lens exchange in emmetropes.
I'm reluctant in emmetropes for either laser refractive surgery or IOLs, and I'm also reluctant to treat the perfect myo being -2, unless either of these are used to wearing contact lenses and know how their vision will change when corrected. In those cases, I will certainly do presbymax.
I mean, I personally was kind of emmetropic, just plus 1.5, and I didn't fear it at all. So I do it in emmetropes without any pain.
Same for here. So treating emmetropic patients, also I simulate them with contact lenses or with glasses, so they can walk around the clinic and then read and look in the far if they tolerate it. So then it's very rare that the outcome is not satisfied for the patient.
Thank you for your feedback.
I mean, what I heard from Alan today, and I really learned it from him, that was a great argument when he said he doesn't do contact lens wear trials. I only do them on a very scarce basis because I think Alan is completely right. Patients don't wear them for 6 or 3 months. What is the time you need for neuroadaptation? So I meanwhile, after eight years of blended vision, I can't remember when I had to do the last retreatment. So I'm really kind of cheeky. I just tell my patients, I will not give you a vision like you had as an 18-year-old one. I have to split up light, and there will be some side effects. And I see all my patients after 1 month, and extremely important after 3 months, because some patients that are not happy, they don't come back. So I want to see them after 3 months. I want them to challenge me. I want them to criticize me if they're not happy, because I'm really deeply convinced with laser vision correction, we can make everybody happy. But he has to come back, and he has to talk to us, he has to criticize us, he has to tell about his problems. And that's a great thing of laser vision correction in comparison to trifocal IOL.
Yeah, good point. Yeah, thank you.
Good comment.
Jens, you have a further question?
Yes, actually an interesting question, a business question. If you perform presbyopia and you know it's going down after a couple of years, how do you first explain that to your patients, and what do you charge for an enhancement that you're going to do? So
it's very important to explain to the patient prior surgery that it's not a life-lasting treatment. So I explain to the patient that they will need a touch-up after around maybe 5 to 10 years. As I'm performing presbymax since around 2 years and a half, I never had the situation so far. But as for charging, probably I would charge them the half price after this time, as it is just a simple touch-up. And I would probably just keep the spherical aberration and just perform a aberration-free readjustment on both sides.
So what I do, I always talk to patients about the concept of social reading and then small print reading, because I think those are two separate things. And you'd be surprised if you divide the reading requirements into those two categories, how patients respond, because the requirement for small print reading is not there for many patients, but many patients do want social reading. So they want to be able to see their computer screen, their phone, the dashboard of the car, to put on makeup, to shave, but they don't need to pick up a small newspaper or a novel and be able to read it in poor light levels. And so I aim to make them all totally independent of glasses for everything initially. But for those that are able to read, but when they're able to read small print initially, if they still have additional presbyopia to come with age, I don't overtreat them by a significant amount, although I think presbyopia does give you a cushion more than if you were just doing a monovision treatment. So it will preserve the reading vision more, as I think Michel showed in his slides. But I will tell them that over 5, 10 or 15 years, they may need a small reading addition for small print reading, and very few are bothered by that, and very few come back. It's the social reading that bothers them. They don't want to be in a restaurant and have to look for their reading glasses when they're out socially. They don't want to be grabbing glasses all the time. If they only have to use them for a very small percentage of the time, they don't tend to complain. And that's one of the things that I mean when I say quality of vision versus quantity of vision. If they're using glasses very rarely, they don't complain. They complain if they need them a lot, and that's I think that if you explain that to them and go through that with them, then they seem accepting of it.
And that's exactly what we noticed also in our studies, that over time, looking at the near vision questionnaires, the performance gets a little bit less, especially for the really up close near vision. But still, patients are quite happy. So we can keep them away from enhancements to a large extent, and still leaving them happy.
And I also think the paradigm these days changes. In the past, people were reading more books, so the distance was much closer. So today we are shifting more to iPad, cell phones. So there is no more need to have such aggressive treatment of presbyopia. So I explained to the patient that I will, as Alan said, I'm not going to treat you that you get a vision at the age of 18 or 20, but the aim is to give to the patient an all-around vision. So sometimes the patient needs glasses for perfect driving in the car, and sometimes they need a small reading glasses to read like medical prescriptions or medical medications texts. So all-round vision, this is my word for the patient.
Victor, I do have a little bit, sorry for that, a little bit another attitude, because I liked Alan's approach to ask the patient what he wants. I think we as doctors shouldn't tell the patient what he wants, but we have to ask him. Some love small print reading and they don't care about car driving or to wear glasses with car drivers. Others are completely different. So I think for me, it's very important to ask the patient what he wants. So if he is very often outside, and some people tell you, I nearly never read a book. I don't read newspapers. I want a perfect vision outside, and I want to read the dining card. That's enough. I treat those different from, let's say, a professor for literature who will read a lot, and this is very important to him.
Agree 100%. Agree 100%. This was just like a general, but I always test the maximum tolerance for each patient, and then if the patient tolerates more, then we give them the full range of presbyopia. I mean, the full correction of presbyopia. But for those who don't accept, then I reduce it and then I explain it. Okay, your vision will not be perfect in the near, but you have like all around the vision. But I agree with you 100%. We should listen to the patient and give the patient the correction which is desired by the patient, not by us, not by doctors.
And make sure, of course, that they have realistic expectations.
Yeah.
Yeah, I think the analogy, the discussion that says you will not have the vision that you had when you were 18 is essential for any presbyopic treatment, because they don't understand the discussion about neuroadaptation, and many come to the clinic with this expectation that you will automatically restore distance and reading vision as it was when they were 18. And I think by explaining that they have to accept some form of compromise, then it's also a way of trying to ascertain where their priorities are, because one compromise is for them to remain in glasses or contact lenses, which they very rarely choose to choose as their preference. But the other compromises are either, like as we've said, either some loss of total independence of glasses, or else potentially, night driving or other things. So it's useful to have that discussion with them.
Okay, as a final question, maybe, do you have one short, quick tip or recommendation for a new beginner with presbymax? What he should consider?
It's a stony way in the road. No, it's not easy. I think beginners should start with hyperopic people or highly myopic. So never take an emmetrope or somebody around that, and set low expectations. Don't ask for a too high price, and be open for criticism and listen to the patients. I think that's one of the most important things I learned in presbyopia correction. Listen to the patients. Don't be too proud. Let them criticize you and adjust the treatment.
Excellent points. Any further comment?
Yeah. I would say that for the monocular presbymax, anyone doing laser vision correction should add that to their list of treatments that they offer. I think you'll try it and you'll like it. I think that there's there's very little downside, and it's potentially of benefit to, you know, a third of the population. So the numbers, those Schwind numbers of 26,000, you know, the next time there's a Schwind user meeting, they should be double. You know, there's many patients that would benefit from this intervention who are not either not aware of it or not being offered it. And I think that Schwind users should try and more widely adopt it. It's been revelatory in my practice since introducing it, and I plan to do it a lot more.
Can I have one question to the other panelists? What is the upcharge that you charge for presbyopia over normal distance correction? What percentage do you upcharge?
For us, it's 25% additional.
So I charge 1,400 euros plus to the regular femtolasic.
2 eyes.
Full eyes, yes. No matter if we treat, like, say, let's say a patient has one eye is emmetrope and the other eye is like -3. So if we treat on the one eye, so I charge always the same, one eye or both eyes, no matter.
Oh, I'm a bad mathematician, so I give you the sum all over is 6,500 euros both eyes.
Okay, gentlemen, and each and every one of you, thank you very much for presenting and your time to listen to all this, for all the attendees. It was great to have you here, and thank you very much, and wishing you that you stay healthy and that you have a good day and a good week. Thank you and goodbye to all of you.
Thank you.
Bye-bye.
Right.
Bye.
Bye.